Hello. So our group is presenting about PTSD. My group member are Holly, Kendall, AB, and me, Fatima. Next. So I'll be talking about the overview of the diagnostic category. Overview of PSTD. PSTD is a psychiatric disorder that may occur in individuals who have faced traumatic events such as accidents, natural crises, sexual abuse, exposure to actual or threatened death, or worse. Individuals can develop PTSD by directly experiencing the traumatic event, by witnessing in person the event as it occurred to others, by learning that the traumatic event occurred to a close family member or close friend, or by experiencing repeated or extreme exposure to aversive details of the traumatic event. That would be the second slide. Individuals with PTSD have extreme thoughts and feelings related to their experience that could last a long time post the traumatic event. Individuals with PTSD may have negative emotional states and feel fear, anger, guilt, shame, and sadness. They may also feel isolated from other people. Individuals with PTSD may avoid situations or individuals that bring back memories from the traumatic event. History of the diagnosis. In the 1980, American Psychiatric Association added PTSD to the DSM-3. From a historical outlook, the important change in the concept of PTSD was that the contributor to the disorder is outside of the individual rather than an inherent individual weakness. The DSM-5 in 2013 was the latest revision of the DSM, where a significant evidence-based revision was made to PTSD diagnostic criteria. PTSD is no longer considered a fear-based anxiety disorder. In the DSM-5, PTSD is classified in a new category, trauma and stressor-related disorders. Recent data from the National Comorbidity Survey replication indicates lifetime PTSD prevalence are 3% American women. Rates of PTSD are much higher in post-conflict settings, such as Algeria, which is 37%, Cambodia, which is 28%, Ethiopia, which is 16%, and Gaza, which is 18%. In the beginning of the 21st century, PTSD was the fastest growing and leading diagnosis in American psychiatry. During the First World War, many soldiers were treated for shell shock, a disorder that included many physical and psychological symptoms. In recent years, shell shock has been perceived as an influential sign of the distress of war. According to an article that focuses on Britain, shell shock is considered an early version of post-traumatic stress disorder. However, shell shock was believed to be caused by wartime medical construction rather than So history, PTSD screening instruments. There are brief questionnaires that may identify people who are more likely to have PTSD. The first one is primary care PTSD screen for DSM-5. So this instrument is a 5-item screen that has been designed to identify individuals with probable PTSD in primary care settings. The second one is SPAN. The SPAN is a 4-item self-report screen derived from the Davidson Trauma Scale. Its name is an acronym for the 4 symptoms assessed: startle, physically upset by reminders, anger, and numbness. The 4 items that make up the SPAN are the items from the DTS, the best, distinguished a sample of patients with PTSD from a sample of patients without PTSD. Strength is the third one, and it's a short post-traumatic stress disorder rating interview. And the last one is trauma screening questionnaire. It's a 10-item symptom screen that was designed for use with survivors of all types of traumatic stress. And if a positive response is indicated, for further investigation of trauma symptoms by a mental health professional may be warranted. So I'll pass this on to AB. Go ahead, AB.
All right. So here we're going to discuss how to diagnose somebody with PTSD, how somebody with PTSD differs from somebody with a similar diagnosis, and as well as how they may present themselves. So as previously mentioned, and we can go to the next slide. According to the DSM, someone diagnosed with PTSD has experienced exposure to actual or threatened death, serious injury, or sexual violence. And this can be experienced in various ways. So witnessing the event occur to somebody else, or experiencing it themselves, learning that such an event happened to a family member or a friend, or repeatedly being exposed to these adverse details of the event, such as like a first responder or a police officer encountering something similar to the traumatic event over and over. So criteria B, the individual must experience one or more of the following symptoms as a result of the traumatic event. So first, intrusions. So this is recurrent, involuntary, and intrusive distressing memories of the event. Nightmares, so recurrent distressing dreams where the dream itself or the affect of the dream is related to the event. Dissociation, so dissociative reactions in which the individual feels or acts as if they're experiencing this event again. So an example of this is flashbacks. And these can occur kind of on a continuum of any extreme. So the most extreme would be like a complete loss of awareness of their present surroundings. Then triggers, so an intense or prolonged psychological distress at exposure to an internal or external cue that symbolizes or resembles an aspect of that event. And then last, physiological reactions to internal or external cues that symbolize or resemble an aspect of the traumatic event they experienced. Criteria C, so persistent avoidance of stimuli associated with the traumatic event. And this must occur either after the event, or this must occur after the event, which can be evidenced by one of the following. So avoidance of distressing memories, thoughts, or feelings related to the event, and or avoidance of external reminders. So this would be people, places, conversations, activities, objects, or situations that remind them of what happened. And next, the individual also experiences negative alterations in cognition and mood. So this has to either occur after the event or worsen significantly afterward. So this can be evidenced by two or more of the following. They can't remember an event or an important aspect of the event. So this occurs typically because of dissociative amnesia. So factors such as alcohol or drugs, those don't count. Persistent and exaggerated negative beliefs about oneself, others, or the world. So examples would be thinking I'm bad, no one can be trusted, or the world is completely dangerous. Distorted cognitions about the cause or consequence, leading to the individual to blame themselves for what happened. Persistent negative emotional state. So examples here would be feelings of horror, fear, anger, guilt, or shame. And then significantly diminished interest or participation in activities that they would have previously enjoyed. Feelings of detachment or estrangement from others. And lastly, persistent inability to experience positive emotions such as happiness, satisfaction, or loved feelings. All right, criteria E. So there's marked alterations in arousal and reactivity associated with the traumatic event that occurred either after or significantly was worsened because of the event. So this is evidenced by 2 or more of the following. So outbursts of physical or verbal aggression towards others or objects, hypervigilance. So this is always being on guard of their surroundings, assessing for threats or danger, exaggerated responses to being startled, problems concentrating, and sleep disturbances. Criteria F. So overall, the individual must be experiencing these disturbances for longer than 1 month. It must clinically significantly distress in their social or occupational functioning or other areas that are important to functioning. And the cause is not related to a medication, alcohol, or any other medical condition. And then specifications. So PTSD can be specified further with PTSD with dissociative symptoms. And then these are broken down into depersonalization and derealization. So PTSD with depersonalization is experiences of themselves as if they're outside of their body or mental processes. So they might feel like they're in a dream, or like time is moving in slow motion, or as if they're outside of reality. And then PTSD with realization is, derealization. This is different because the individual surroundings are what they have a sense of unreality for. So before it was they feel out of it, but now reality doesn't feel so real. So for example, as if the world around them is distorted or dreamlike or distant from them. And then PTSD with delayed expression. This occurs if the full diagnosis criteria is not met until a minimum of 6 months post the traumatic event. So now we're going to switch gears into how to differentiate someone with PTSD from others with similar diagnosis. So off to Kendall.
Okay, so for this slide, here are a few of the common symptoms associated with PTSD, including avoiding thinking of trauma, avoiding talking of the trauma, avoiding different places and activities, being easily frightened, having flashbacks, being in a negative mood, being unable to concentrate, constantly having negative thinking, aggressive behavior, and always being on guard. Okay, so for the next few slides, we will be differentiating PTSD from similar diagnoses. So for adjustment disorders, the stressor can be of any severity or type. The response to a stressor meets PTSD criterion A, but not all other PTSD criteria. Symptom patterns of PTSD occurs in response to a stressor that does not meet the PTSD criterion A. So for OCD, or obsessive compulsive disorder, the recurrent intrusive thoughts are of an obsessive and not related to an experience or a traumatic event itself. And for anxiety disorders, the symptoms of panic disorder and generalized anxiety disorder are not associated with a traumatic event either. So symptoms of separation anxiety disorder are clearly related to the home or the family rather than a traumatic event itself. So for acute stress disorder, symptoms are restricted to the duration of 3 days to 1 month following the traumatic event. And for major depressive disorder, it may or may not precede a traumatic event. It should also be diagnosed if other PTSD symptoms are not present. Specifically, major depressive disorder does not include criterion B or C, nor several criterion D or E symptoms as well. So for personality disorder, someone with PTSD would experience an onset of interpersonal difficulties as a result of a traumatic event. Pre-existing difficulties significantly are exacerbated after exposure to the event. And for dissociative disorders, they may occur comorbid. This associative disorders may present itself prior to exposure to a traumatic event as well. For psychotic disorders, flashbacks that occur as part of PTSD must be determined separate from illusions, hallucinations, and other disturbances occurring in psychotic disorders such as schizophrenia and bipolar disorders. For traumatic brain injury, symptoms can overlap between TBI and PTSD, but some are isolated to one diagnosis or the other. For example, persistent disorientation and confusion are more specific to TBI, and re-experiencing and avoidance are more specific to PTSD. So here are video examples or video case examples of individuals suffering from PTSD. We can't hear it.
I didn't even want to go to sleep. The nightmares were so bad.
That image kept coming back to me. I didn't want to remember it, but there it was.
I felt like I was right back there in the middle of that horrible day. The smells, the sounds, it was so real.
I tried to go grocery shopping, but I couldn't be around all those people without seeing the exit.
These are the voices of post-traumatic stress disorder, or PTSD. Almost everyone lives through something traumatic at some point in life. Most people have a lot of distress right after a trauma happens, but begin to feel better over time. For other people, the distress sticks around, and they begin to have symptoms that really affect their lives. For these people, it is almost as if the trauma is still happening, all the time, everywhere, long after it has passed. I know, one of these voices is mine. What do we mean by trauma? When we're talking about PTSD, a trauma is a horrible experience where you might have felt afraid for your life, or you were injured physically or sexually, or were afraid you would be. You can also witness a trauma or hear about it happening to someone you care about. First responders, medical people, and clergy can also experience trauma by hearing others talk about it. For me, it was combat. I saw some really horrible things, and I often thought I might be killed. PTSD develops in some people and not in others. Everyone experiences horrible things differently, and everyone reacts differently, sometimes for years or decades after the event. If you experience post-traumatic stress, it does not mean you're weak or that you can't handle hard things. It may make you feel weak or unsafe, but a lot of strong, brave people are affected by PTSD. And it is treatable. Your provider might think about a diagnosis of PTSD if you've lived through something awful, and if you have some specific symptoms for more than 1 month. Intrusion or re-experiencing symptoms. This is the memory of the trauma coming back. It can show up as unwanted memories, nightmares, flashbacks, or feeling horrible after being reminded of it. For me, I kept seeing this one image of a Marine who had just died, and that memory haunted me. Avoidance symptoms. People go out of their way to avoid anything that reminds them of what happened. Some people avoid things like thinking about the trauma. Others avoid people or places or anything else that makes them remember. I couldn't deal with crowded restaurants or movie theaters. I felt unsafe there, so I stayed away, and it affected my family life a lot. Negative changes in thoughts or feelings. This can seem like depression or thinking I'm not safe. I felt sad and didn't feel interested in the activities I used to love. I isolated myself. Other people feel self-blame or might not remember the event well. Some people feel numb or disconnected. Changes in reactivity or arousal. This means your body reacts to things much more than it used to. You feel irritable. You might take risks or act self-destructive. A lot of times you have trouble concentrating and you're always on guard. I was jumpy and loud noises really startled me for a while. I also couldn't sleep for months after coming home and had to take medication. PTSD makes people feel horrible, but I found a way to ask for help. I learned there are several treatments proven to work for combat veterans like me, as well as for survivors of all other types of trauma. These therapies have names like CPT, PE, and EMDR, and they help people get through the trauma by learning to change how they think and feel about it. I was able to get back to living. PTSD is challenging, but there is hope. Talk to your doctor and get some help because treatment works. People can learn to live again. I know. I did.
My situation was that we were on mission. We were heading north. The truck in front of us hit a roadside bomb. There were no survivors. I had injured my back, my head, and my arm. The passenger that was sitting in the seat where I was supposed to have been sitting had injured his entire right side. That's something I've carried with me and I'll always carry with me. I was diagnosed with PTSD when I came back in October of 2004. I started having nightmares. They had to put me on sleeping pill for that. They had to put me on anxiety medication for it because I was having panic attacks daily for it. Found out the sleeping pill wasn't working. I started having breakthrough dreams. I didn't want to work. I didn't want to leave my house. I didn't want to do anything. I was getting in trouble at work. One day I guess you could say I went off and I cussed out my NCO, my platoon leader. And he was going to write me up, and my first sergeant stepped in and said, no, she's going to go see the psychiatrist. I found a counselor that said, okay, you can't do this anymore. You've got to face what's really going on. And now I've got a great support team. I am doing better, and that is due to the one-on therapy that I get. It is due to the VA doctors here that I see in DC. I owe a tremendous thanks to the counselors that I've got. Everybody should take the chance and seek out their VA system. I think that's one of the most important things. I can't stress it enough.
Okay, so we're going to continue by passing it to Holly to now discuss the evidence-based interventions.
So for the first evidence-based intervention, we have eye movement desensitization and reprocessing, also known as EMDR, one of the therapies that was mentioned in the video. So this is an up-and-coming evidence-based practice that's been used to treat PTSD. According to the EMDR Institute, this therapy was originally designed to alleviate distress associated with traumatic memories. It allows for the accessing and processing of traumatic memories and life experiences to bring them to an adaptive resolution. It helps to reduce emotional reactivity to traumatic events by focusing directly on the memory rather than the emotions, thoughts, and responses resulting from traumatic experiences. It helps to create new associations that are believed to facilitate complete information processing, new learning, elimination of emotional distress, and development of cognitive insights. So the EMDR approach uses a 3-time period approach. So the first is the past events that have laid the groundwork for dysfunction, and those are processed to forge new associative links between adaptive information. Second, the current circumstances that elicit distress are targeted and internal and external triggers are desensitized. And for the third, imaginal templates of future events are incorporated to assist the client in acquiring skills needed for adaptive functioning. And now for the EMDR treatment phases. So treatment occurs across the course of 8 phases. The first phase is history taking. So during this, the therapist evaluates the client's readiness and together they create a treatment plan. They identify targets for EMDR processing, including memories and situations that cause emotional distress. Specific skills and behaviors that will be needed by the client in the future situations are explained. The second phase, the therapist prepares the client by identifying different coping strategies for emotional distress, including imagery and stress reduction techniques the client can use during and between sessions. A goal of EMDR therapy is to produce rapid and effective change while the client maintains equilibrium during and between sessions. For phases 3 through 6, EMDR procedures are used to identify and process a target. The client identifies the vivid visual image related to the memory, a negative belief about the self, related emotions, and body sensations. They're also asked to develop a positive belief. They rate the intensity of this belief as well as the intensity of the negative emotions. They are then asked to focus on the image, negative thought, and body sensations while simultaneously engaging in EMDR processing using sets of bilateral stimulation. These sets may include eye movements, taps, or tones. After each stimulation set, they're asked to let their mind go back and notice whatever thought, feeling, image, memory, or sensation comes to mind. Depending upon the client's report, the clinician will use the next focus of attention. These sets are repeated with directed, focused attention for the remainder of the session. If the client experiences too much distress or is having too many difficulties, the therapist follows procedures to put them back on track. If they report no related distress to the target memory, they're asked to think of a positive belief from the beginning of the session and focus on it for the next set. In phase 7, during closure, the client is asked to keep a log of anything related to their EMDR processing. The intention for this is to remind them of self-calming techniques from phase 2. For phase 8, the therapist and the client discuss the progress so far. The EMDR treatment processes all of the related historical events, current incidents that elicit distress, and future events that will require different responses. And now we have cognitive processing therapy, which again was another one of those therapies that was mentioned in the video. So this is a form of cognitive behavioral therapy, or CBT, which helps the patients learn how to modify and change unhelpful beliefs related to trauma. This is effective in reducing symptoms for many types of trauma and is a very widely used practice. It's delivered across 12 sessions, which begin with psychoeducation on thoughts, emotions, and PTSD and how all of those are linked. And it involves identifying automatic thoughts that happen and creating an impact statement for those. It focuses on formal processing of the trauma through a written account of the traumatic experience that the person went through. And then from that, we have Socratic questioning that happens through the therapist. The client is taught to use skills to continue evaluating and modifying beliefs and how to use these adaptive strategies that they learn outside of treatment. And now we have the implications of diagnosis and intervention. So the question is, does this diagnosis seem logical and well-founded? So this diagnosis is well-founded in the very real implications that traumatic experiences and memories can have on day-to-day functioning. So people who have this diagnosis may possibly experience sensory triggers. So these would be commonplace sights, smells, or sounds that remind them of the event. Distressing dreams and thoughts related to trauma. There can be behavioral reactions like exhaustion, numbness, dissociation, and anxiety. And this can also have an impact on their relationships because due to having this diagnosis and the issues that come with it, they may have trouble communicating what they're feeling. They can't talk about trauma. Or again, as mentioned in those videos, they might have trouble with symptoms that are similar to depression, to where they can't leave the house and things of that nature. For young people who carry a PTSD diagnosis, some of the negative connotations could be stigma and stereotypes that come with this diagnosis. For example, that having a mental health diagnosis is bad, or that there's something that's wrong with you because this traumatic event has such an impact on you to warrant receiving a diagnosis. There could also be the fear of hospitalization. So not having this diagnosis, but like given by a professional, but still experiencing all those symptoms, you could be afraid that if you go and try and talk to your doctor about what you're experiencing, that they're just going to put you in the hospital, and then you're not going to be able to do the things you want to do or continue living your life the way you want to, because you have to go through this, and hospitalization is not an easy thing to experience. And then there can also be worry about the diagnosis impacting employment. So for example, being afraid of not being able to follow certain career pathways, or being denied a job due to your diagnosis of PTSD. Some of the positive connotations are that by getting a diagnosis of PTSD, there can be comfort in having a diagnostic label to validate your symptoms. So you're experiencing all these things, and then you go and you get this diagnosis, and it makes sense that this is something that's impacting your life. So that can make you feel better just to know that it's actually something. And then there is also a direction to go for in seeking treatment. You can find out what sort of treatments may be helpful for you, and potentially by going through those treatments, the symptoms can go away or not be as severe as they were before. And now some implications for the intervention. So does this intervention seem logical and well-founded? Both EMDR and CPT are based on years of PTSD research, and they've been clinically demonstrated to help reduce symptoms of PTSD. They both carry a recommendation from the APA to be used for treatment of PTSD. Both are logical in that they're intended to address the root of trauma and help clients learn how to heal and use different coping strategies. And in the case of EMDR, change the reactions that you have to those traumatic memories that you experience. Some of the potential positive connotations are that they can facilitate stronger relationships by reducing those symptoms. Individuals may be able to be more present with the people that they have relationships with and be more involved. It can increase personal growth, again, by reduction in symptoms, potentially being able to facilitate just more helpful functioning in day-to-day life, a greater awareness of potential possibilities, a deeper appreciation of life by reduction in symptoms, and then some potential negative connotations are re-traumatization, because in EMDR, you're re-experiencing some of those thoughts and feelings that you have that are tied to those memories. So that could potentially be something that turns off people to getting this type of treatment. Same with CPT, because again, you're having to re-experience a lot of those things. But hopefully we can get some of those positive connotations after going through treatment and having that symptom reduction. And to finish up, this is a list of references that we have. We appreciate your time, and thank you for listening.